prevention, treatment, and the latest advances. My name's John Day. I'm a cardiologist specializing in atrial fibrillation treatment. We have over 200 registered online. Over 100 have already logged on, so more will be joining. We can take your questions both online as well as in person. As mentioned, if you have a question for those here in person, press your microphone and it will light up red so I can see it. So with that, let's jump in. First question, what is atrial fibrillation? Well, as seen by this cartoon here, atrial fibrillation represents total electrical chaos of the upper chambers of the heart. As you can see here, this is a heart. You have the two upper chambers, the right atrium and the left atrium, and then the ventricles below. And you can see the areas shaded there in kind of a darkish color represents scar tissue that has developed over time in the atria, disrupting electrical pathways. And you can see lots of little circuits bouncing around everywhere. So it's total electrical chaos at the upper chambers of the heart. And all those chaotic signals tend to lead to a very rapid heart rate. And it's that rapid heart rate that often causes the symptoms, the heart failure, stagnant blood flow becomes very stagnant in the upper chambers because with all that chaos, the upper chambers are not pumping at all. They're almost just quivering from all these crazy electrical signals, and that can lead to clots and strokes and all the other fun things that go along with atrial fibrillation. One of the questions I'm often asked by patients when I'm seeing somebody for the first time with atrial fibrillation is, how did I get this? Why me? Well, I would almost say, why not you? Atrial fibrillation is very common. In fact, among Caucasians in the United States, some studies now are reporting that 1 in 3 Caucasians in the US will have an episode of atrial fibrillation at some point during their lives. It's very common. And many times patients are very surprised. They start telling their friends and they find out that every single one of their friends knows somebody else with atrial fibrillation. It's a very common condition. And like I said, it's something that does tend to get older as people get older. So genetics plays a role, especially with Caucasians. If everybody in your family has atrial fibrillation, guess what? You probably inherited several atrial fibrillation genes. Age plays a role, and I'm going to show you a chart here in just a minute, but roughly every decade more of life you live, the chances of you getting atrial fibrillation double. So as you get older, your chances of getting atrial fibrillation go up. Being overweight is a common risk factor that we see. All of that extra weight puts a strain on the heart, which over time can lead to scarring of the upper chambers, which then disrupts electrical pathways and puts you at risk for atrial fibrillation. The good news is, if you want to reverse atrial fibrillation naturally, then dropping that extra weight is the very best thing you can do to try to reverse atrial fibrillation naturally. And we're going to talk a little bit more about that. Stress. Stress is another huge risk factor. People who are under a lot of stress, especially that chronic stress, everyday stress, the person who takes on everybody, all the stress of everybody in their family, they're the people that also puts them at higher risk of atrial fibrillation because all of that stress leads to a lot of extra adrenaline release, cortisol release, lots of other pathways, which the end result can also be scarring of the upper chambers of the heart. Diabetes, big risk factor. If you've got adult onset diabetes, you want to reverse that as quickly as possible. Diabetes not only is bad for AFib, but about every other organ in the body. Sleep apnea, common cause. If your sleeping partner snores like a bear, and then they stop breathing for a period of time at night, and then they start having this huge gasp, and then they once again go back to this crazy loud snoring that won't let you sleep, odds are they've got sleep apnea. Sleep apnea is another big trigger of AFib. High blood pressure, very common cause of atrial fibrillation. High blood pressure, what that means is the heart is pumping against a heavy load. And by pumping against that heavy load over time, it puts stress and strain on the heart, which can disrupt electrical pathways, and once again lead to that cartoon where you've got electrical signals going everywhere. Too much or too little exercise. What does that mean? If you are a couch potato, your risk of AFib goes way up. On the other hand, if you are competing in the Tour de France, or you are an ultra marathon runner, or you run lots of marathons at fast times, you are also at increased risk of AFib. Exercise is very, very, very important for the heart and very, very, very important to prevent AFib. But exercise can kind of be thought of as like a U-shaped curve. The couch potato is at very high risk of AFib. The person who doesn't like to exercise, high risk of AFib. The person who is an exercise maniac, they're like exercising 3, 4, 5 hours a day, they're also at risk of AFib just because of the strain they're putting on their heart. And then any other heart problems. If you've got valve problems with your heart, that is a big cause of AFib. Heart failure, big cause of AFib. So other heart problems, even blockages in your arteries do increase your risk of AFib. So why did you get AFib? What we generally find is every new patient that I see in general will have at least 2 or 3 things on this list. Risk of AFib by age. There is age-related fibrosis. The longer you spend on this earth, the more fibrosis or scarring you pick up in the upper chambers of your heart. Now, you can determine how fast or how slow you age. In general, you can see that if you start here, if you start here, you can see on the left, 40 to 49 years old, 50 to 59, 60 to 69, and above 70. For every 10 years of life you got underneath your belt, it doubles your risk of AFib. So that you can see, going from 40 to 50, your risk of AFib is doubled. Going from 50 to 60s, risk of AFib doubled. Going from 60s to 70s, risk of AFib doubled. So you can see if you live long enough, it becomes harder and harder to avoid atrial fibrillation. But age studies show that your biological age can be reduced by about 10 years with healthy lifestyle. So you can, if you will, turn back the clock on your heart. And that is the good news here. So this is a nice diagram here. And you can see our newly diagnosed atrial fibrillation patient is down in the bottom left corner. They're younger, and they look at themselves in the mirror, and their biological age looks about the same as they appear. However, you get to decide whether you want to go on the accelerated aging program, the decelerated aging program, or the normal aging program. You can see on the accelerated aging program, in real life, they don't look too old. But in the mirror, looking at their biological age, they're aging really fast. In other words, their insides are a lot older than their outside appearance. Then there's normal aging and then decelerated aging or slow aging. You can see on the outside, they look like they're an older person, but their biological age is still very young. And that is something that is up to us to decide. How? Well, if you want to go on the accelerated aging program, what do you need to do? Be a couch potato. You need to not sleep at night. So don't sleep if you want to go on the accelerated aging program. Smoking. Smoking is great. Tobacco in any form is a great way, a great plan if you want to go on the accelerated program. Fast food, junk food, eat all of it if you want to go on the accelerated aging program. Stress. Throw as much stress on your life as you can. That is a great plan if you want to go accelerated aging. How many want to do the accelerated aging program? All right, good. Nobody's hands went up. All right. What we don't want normal aging. We want decelerating aging. And by this pathway, you can reduce your biological age by about 10 years. And we talked about every 10 years you add on your life, you double your risk of AFib. So what do you need to do if you want to go on the slow aging pathway? Exercise every day. Learn to love it. Everyday activity. In other words, you don't just sit at your desk all day long and then do a quick workout at night. No, you're active through the day and you do your workout. You do both. Sleep time. You prioritize sleep time and quality sleep. In other words, you sleep well. You don't have sleep apnea. You're not snoring at night. You're sleeping at least 7 hours a night. And 7 hours seems to be the criteria to optimize your risk of your chances of avoiding atrial fibrillation. Appropriate nutrition. Lots of vegetables, lots of healthy stuff. Sugar, fast food, processed food, packaged foods shouldn't be there. As much incorporate as many natural, whole foods, plant-based foods as you can. As far as meat, lean proteins, fish is probably the best source of meat. Eating right. Also, relaxation techniques and keeping your weight in check. You do all this, you're on the slow aging process, and studies show you're aging about 10 years below how many candles are on your birthday cake. So we talked about one of the causes of atrial fibrillation is carrying extra weight. The very best thing you can do if you're carrying extra weight is to drop that extra weight. Now, yo-yo dieting is not good for AFib. In fact, yo-yo dieting may undo or even make things worse. So if you're going to commit to this, you got to commit. The yo-yo dieting approach, not so good. But this was a landmark study, you can see published in 2015, where they showed in this study, the bottom line of this study is they had overweight patients with atrial fibrillation. And they put them through an aggressive lifestyle optimization program, which included weight loss. And what they found is that on average, they dropped about 35 pounds. And half of these patients were able to put their atrial fibrillation into remission without drugs, without procedures. So huge, but it's also not easy. You've got to commit. Diets, guess what? Diets don't work. It's lifestyle. You commit to a healthier way of eating. This was a study that we published a number of years ago where we showed that even just dropping 5 pounds can statistically improve. These were in our patients who had had an ablation, but just dropping 5 pounds statistically improved the chances of an ablation taking care of your AFib. Ablations are wonderful technology, and we're going to talk about them tonight. And there's been great technological changes. But if you want to make that ablation stick for the rest of your life, healthy lifestyles need to be there. It's kind of like going to the dentist. Your dentist can drill and fill your cavities, but if you just keep eating junk food and you don't brush and you don't floss, guess what? You're going to be back for more drilling and filling. We don't want that. If you want it to work, that is one way that can really help tip the scales in your favor. This was a study published in a very prominent medical journal a number of years back, showing that what you can see is you can see waist circumference on the bottom and then how physically active they are. So the couch potatoes are in the green. And what you can see is as their waist circumference goes up, and this is in centimeters, as their waist circumference goes from 92 centimeters to greater than 106 centimeters, you can see in green, the couch potatoes, their risk of AFib goes up. That's a bad combination. A high waist circumference and being a couch potato. Red is the intermediate exercisers. They occasionally work out, or they try to work out, but a lot of times they miss it. You can see once again, as the waist circumference goes up, People with the intermediate levels of exercise, their risk of AFib goes up. The blue are the ideal. So you can see if you've got a big belly, even if you are working out hard in the gym every single day, that big belly, you can see is putting you at risk of atrial fibrillation. What is remarkable here is if you can take the couch potato in green and just get them to think about exercising occasionally, you can cut their AFib burden in half. So taking a couch potato and getting them to do something can cut their AFib in half. For those who are already exercising, it still can help. We want to keep it. We want to keep it. So at any level, any waist circumference, any level, exercise is good for dropping AFib, unless you want to do like the Wasatch 100, which is a 100-mile ultra marathon. Now, that wouldn't be so good for your AFib. But short of running an ultra marathon, the more the better. All right, next. What are the AFib symptoms? We talked a little bit about this. Fatigue and shortness of breath are the two biggest symptoms. A lot of people say, I don't feel my AFib. Well, are you tired? Yeah. Do you get short of breath walking upstairs? Yeah. Well, those are your AFib symptoms. Palpitations, most people feel like I should feel the palpitations. Surprisingly, many of our patients, what do you say, Sherry? Most of our patients. Yeah, less than half of our AFib patients. And this is Sherry. If any of you have had an ablation, you've met Sherry. You know Sherry. Sherry is your best friend if you've ever had an ablation. But what you'll find is that less than half of our AFib patients feel palpitations. But fatigue and shortness of breath, they almost all have fatigue. The shortness of breath isn't at rest. The shortness of breath is with exertion. Rapid heart rate is common, but a lot of people don't feel it. Chest discomfort, occasionally. Dizzy, lightheaded, occasionally. Brain fog, we find a lot of our higher functioning, our college professors, our physicians, our whoever is just really has to have perfect concentration during the day, they find that their brain is a little bit foggy when they're AFib a lot of times. Decreased exercise tolerance. They just find that when they're in AFib, they're short of breath with minimal activity. Anxiety. It's a strange thing they feed off of. Anxiety can cause AFib, and AFib causes anxiety. It's like a vicious circle. And a lot of people, even people who don't suffer from anxiety, while they're in AFib, they just feel anxious. And we get rid of the AFib, and their anxiety goes away. So anxiety and AFib often go hand in hand. Fainting is rare, but can occur. And that's a worrisome symptom because those patients need to be treated right away so they don't get hurt from AFib. So why is AFib dangerous? Studies suggest a 5-fold increased risk of stroke with AFib. Dementia risk is doubled. Our research was some of the first demonstrating that if you want optimal brain health, you need that regular blood flow to your brain. Heart failure risk is up to tripled. Kidney failure risk is up to doubled. Premature death is up to doubled. So AFib is not good for your organs. It's not good for your longevity. It's not good for about anything. So if possible, getting out of it sooner rather than later. And the sooner part, emphasizing, studies show the sooner you can get it treated, the better off you'll be. If AFib has been going on for years and years, we may not even be able to get you back. You'll just have to live your life out of rhythm, and some people do. Our former president, George Herbert Walker Bush, lived the last 20, 30 years of his life in AFib, and he was still jumping out of airplanes in his 90s. So you can still live with AFib. How is AFib diagnosed? The key is we need an EKG or an ECG. What's the difference? They're the same. If you're in Germany, it's a K because cardia for heart. If you're in the US, C for cardiac. So if you have an Apple Watch or one of these other devices, they usually call it an ECG. A lot of times medical providers will just call it EKG. Maybe it rolls off the tongue easier. ECG, EKG, they're all the same. Apple Watch, we love them. Fitbit watches that can detect AFib, we love them. Whatever smartwatch you have that can detect AFib, whether it's a Samsung watch, pick your watch, we love them. That is a way to be aware of what's going on, since most of our patients don't feel the palpitations. Also, if you're on a budget, the AliveCore monitor or Cardia monitor is fantastic. It's a little pad, you put your fingers on it, you record an ECG, it sends it to your phone. They now have one that comes in a credit card size. The only downside of it is you have to remember to do it, because if you don't do it, you may not know if you're having AFib or not. That's where the watches are nice, because the watches, most of the watches can watch you. But this device, you've got to do it manually, but you can get them as cheap as $79 at Best Buy or online through Amazon or wherever you shop. AFib treatment strategies. 1, lifestyle optimization. That's what we've been talking about. A lot of people, if they jump on lifestyle optimization early, can put it into remission. Also, even if you can't put it into remission, don't feel bad. About half of our patients can't. They may need an ablation or other treatment. The beautiful thing is, our research and others have shown, if you have a healthy lifestyle, your chances of an ablation working go way up. And especially weight loss. Avoid triggers. What are the triggers? Alcohol is one of the biggest triggers. I would just say, if you enjoy alcohol, keep the dose as low as possible. The lower the dose, the better. The next big one, dehydration or electrolyte depletion. Very, very, very common. It's almost up there with alcohol, but getting dehydrated puts your risks of an AFib episode way up. Also, if you have a really stressful day, your risk of going into AFib that day, studies have shown, goes up like 5 times higher to have an AFib episode that day. So a really stressful day, AFib risk for that day, 5 times higher. Lack of sleep, a really bad night of sleep, studies have shown your risk of going into AFib that day are about tripled. So taking care of yourself, very important. Number 3, medications. Most AFib patients are prescribed blood thinners and rate controls. By blood thinners, the most popular one we're seeing now is Eliquis, followed by Xarelto. They're nice, they're quick, they're easy. It's not like warfarin where you have to come in and have blood tests and watch your diet and everything else. So Eliquis, the most popular one we're seeing, followed by Xarelto. The rate controllers. These are medicines to slow your heart down. For most of our patients, when they go into AFib, their heart's going fast. The number 1 rate controller we see is metoprolol. It's a very safe drug. It's a beta blocker, slows down the heart, also helps with blood pressure. Probably the second most commonly used rate controller medication we see, diltiazem. Either one works. The goal is to keep your heart from going too fast. We don't want your heart to go so fast and have you wind up in the emergency room in heart failure from your AFib. That would be a bad day. Rhythm drugs used to be used very commonly. What are the rhythm drugs? These are your antiarrhythmics. Amiodarone, flecainide, propafenone, Sotalol, Ticacin. As I'm saying this, I'm seeing a lot of scowls in the audience. That means you've probably tried one of these drugs. These medications were commonly used in the past. Now, as ablation technology is getting so much better, we are seeing less and less of these drugs. It used to be all of our patients had to fail an antiarrhythmic first before we could consider an ablation. Now, with people who are just recently diagnosed with atrial fibrillation, many are skipping the antiarrhythmics and going straight to ablation. And even with these rhythm drugs, studies suggest, on average, they only give you about 1 or 2 good years of normal rhythm, and then people start breaking through on them. So, but they can be very helpful in some people, and some patients respond well to them. Ablation, number 4. And this has especially changed now with pulse field ablation. So the days when we used to burn the heart with radio frequency or freeze the heart with cryo, those days have passed. We were the first center, the first hospital in the Mountain West states here in the United States to get this technology. We have more experience with this than about any other hospital in the US, maybe even most places in Europe. Europe got the technology 3 years before we did in the US. We have a lot of experience with this. This is what we do. It is a much faster, safer, and far more effective procedure than we ever saw with radio frequency or cryo. And so I'd been involved with that research for years before it was released. I knew it was coming, and we jumped on that train because we knew that that was what was going to help our patients the most if an ablation had been considered. And now, one by one, every single hospital now in the state of Utah has finally switched over. A lot of them came kicking and screaming. Sadly, only the VA here in Utah still, they can't get that technology for their veterans, which is a shame. But this is a game changer, and you are going to see my prediction, and I've told you this at seminars before, it's just a matter of time, and everyone will finally make the switch. So this is something important. As we talk about atrial fibrillation, we need to review the CHADS-VASc scoring system, because the CHADS-VASc scoring system factors in to how we approach atrial fibrillation. Whether we look at an ablation or not, this is important. The CHADS-VASc scoring system is what determines whether or not you should be on a blood thinner or not. It's a mnemonic. Now, this system keeps changing, I admit it, and it's due for another change, because as I go through this with you, you're going to say, that doesn't make sense. And guess what? You're right. But this is what we have to work with. So it's a mnemonic. The C in the CHADS-VASc scoring system is congestive heart failure. If you have ever been diagnosed with congestive heart failure, guess what? You get 1 point. And in this game, the lower your points, the better. You don't want points. So if you've ever been diagnosed with congestive heart failure, you get 1 point. H stands for high blood pressure. If you've been diagnosed with high blood pressure, you get a point. Once again, those are bad points, because these points increase your risk of an Afib stroke. A stands for age. When you turn 65, you get a point. Lovely, right? D stands for diabetes. This is another bad point, because diabetes increases your risk of an atrial fibrillation stroke. S stands for prior stroke, and we also put TIAs. TIAs are like mini strokes. They also go into that same category. That gets you 2 points. Those are doubly bad. So if you've had a prior stroke, not good. V stands for vascular disease. What do we mean by vascular disease? We're talking about a blockage or a stent anywhere in your body. Could be in the neck, could be in the legs, could most commonly in the heart. If you've had a blockage of any artery in your body, you get a point. Uh-oh, age came up again. When you turn 75, you get a second point. So they start stacking it against you. Now, this is the one that doesn't make sense. S for sex, meaning female gender. If you are a woman, you get a point. But. So the early studies suggested that women were at higher risk of AFib strokes. But now more recent data is showing not so fast. That doesn't seem to be a risk factor for stroke. So rather than taking it out of their mnemonic, now in Europe, the mnemonic is CHADS VA. Okay? But in the United States, they wanted to keep the S. And why we have a C, that doesn't make sense. But anyway, so we wanted to keep the S in the United States. But I'm going to show you what they do about it. So if your score is 0, congratulations. If you have Afib and your CHA2DS2-VASc score is 0, you are at low risk for stroke. Blood thinners are not needed. If your CHA2DS2-VASc score is 1, then no blood thinners. Or well, we're going to go through this. No blood thinners if you are a woman. Blood thinners are possible if you're a man. Okay, so it doesn't make sense. Aspirin is okay. If your CHA2DS2-VASc score is 2 and you're a man, blood thinners for life. But for women, they gave you a point, but then they take away a point. This is why it doesn't make sense. In Europe, they just decided to do it CHA2DS2-VA. But for a woman in the United States, it's a CHA2DS2-VASc score of 3 for blood thinners. Now, what else? High blood pressure can be reversed. I've seen many patients with who had optimized their lifestyle, got their weight down. Guess what? Their blood pressure went down. They got off their blood pressure medicines. For patients whose blood pressure is now normal without medications, I don't count that. So you can take away a point for that, or a lot of people can, with healthy lifestyles. Also, diabetes often can be reversed. Same thing. Change your diet, drop some weight, and for a lot of people with adult onset diabetes, they may be able to put it in remission. And so for those patients who can get their hemoglobin A1C down without medications, I don't count diabetes anymore. So, what if the medical guidelines, and we just covered the medical guidelines, say blood thinners for life, but you don't want to take them due to bleeding issues, cost, active lifestyle. Maybe you like to ski. There are a lot of people that like to ski here in Utah. What if you like to mountain bike? We have a lot of people who love to mountain bike. Wouldn't be so good if you hit your head on a tree skiing or go over your handlebars if you're a mountain biker. And then there are some people who just are scared to death of blood thinners. What are your options? Well, one option that is in the guidelines is a Watchman for those who have a CHA2DS2-VASc score of 3 or higher. And I'm just going to play a quick video showing you what a Watchman is, or a left atrial appendage closure device. There are other ways to do this. Surgeons can do it at the time of open heart surgery. They can suture it off or staple it off. Also, there are other devices. Also, the amulet is another device in the US, but the Watchman is the most common. And I'm just going to show you really quickly what one of these things are. Hey, it's playing, fabulous. And I'm just going to skip ahead if I can here. So the implant procedure, really quickly, this is how you do it in 1 minute. It goes in through a vein in the leg. So it follows a vein up to the heart. You go across a membrane called the interatrial septum, and then you identify the left atrial appendage. A catheter goes in to identify this pouch in the heart, and this dead end pouch is where strokes tend to form in atrial fibrillation. Here's the Watchman device. It seals that off, and then over time, your body forms a layer over the top, and then it just becomes part of your body, and it stays in your heart for the rest of your life. But what if that doesn't appeal to you? You're like, I don't know if I want to do that. There is another option. This is not yet part of the guidelines. So for those of you who I'm not taking care of you, if you have another physician, your EP or cardiologist may or may not believe in a pill in the pocket approach or blood thinners as needed approach for atrial fibrillation. There have been a number of studies, but this is not yet part of the guidelines. So even with my own patients, I tell patients about it, but I also tell them, you've got to accept responsibility for this because I can't tell you to do this. Studies show that it works, but I'm held to the standards of the guidelines. If you are willing to take responsibility for yourself, I have seen it work. I've seen it work, and I'll tell you for which patients it works for. So there have been a number of studies published to show that it may work. But these are not yet the kind of studies that are a high enough level of proof that the guideline writers believe them yet. But there is one study coming down the pipeline this year. So they're not part of the official Afib guidelines. So your doctor may or may not believe in blood thinners as needed or a pill-in-the-pocket approach to blood thinners. For now, the patient needs to shoulder responsibility because physicians are held to the guidelines. So I cannot recommend this, but it is a pathway if you're willing to take responsibility. What do I have my patients do? This is the way we do it. If patients say, no way, doc, I'm not taking those blood thinners, I don't want a Watchman, I want to do it this way. So what we have them do is to run an ECG daily. They have to commit once a day for the rest of their life, run an ECG. It only takes 30 seconds. It's faster than brushing your teeth, but you've got to remember to do it because if you forget, you're putting yourself at risk. And what they do is if Afib pops up, they will jump on Eliquis or Xarelto for 1 month, and then they will call and notify us. So 1 month, and then after the month, if the Afib, since the Afib's gone, then they would cycle off of it if the Afib is gone. But it only works in select patients. Number one, they've had a successful ablation. I've had patients try this who have never had an ablation. We saw some strokes. It is not recommended. You want to make sure the Afib is gone before you try to do something like this at home with no recurrences. Also, they wear a smartwatch. I don't like the Cardia mobile monitor for this because humans will be humans and they'll forget to check their ECG. The smartwatch is a second layer of protection. We especially like the Apple Watch at this. We'll turn on all of their alerts, and then if the alerts pop up, they jump on Xarelto or Eliquis for a month and call us. And then we'll bring them in and verify their Afib. And these are only educated and motivated patients. If you're not willing to be all over your heart, this isn't for you. If you're not willing to take responsibility, this is not for you. If you're not willing to try to figure out what the ECG is telling you on your watch, this is not for you. But for the educated and motivated patients, this can be an excellent approach. There is a study. This study will be finished this year. We've been waiting for this study for many years. It's called the Ocean Study. They enrolled lots and lots of patients from lots of medical centers around the U.S. These patients all had a perfect ablation at 1 year. In other words, they had an ablation, 0 recurrences for a year. They were then randomized to low-dose Xarelto. I say low dose because that's 15 milligrams. The standard dose of Xarelto is 20 milligrams versus a baby aspirin. If this study is positive, they will change the guidelines. And if they change the guidelines, then what I recommend to my patients will also change. So this study is due out this year. I can't wait to see it. If it was done right and they picked their patients right, my guess is it's going to be positive and it's going to be a new option for Afib patients. But once again, this takes a very motivated and educated patient who has had a successful ablation and they feel very, very, very comfortable with their smartwatch. Okay, new treatment strategies for Afib. This is what we are so excited about. Pulse field ablation has completely changed the way we approach atrial fibrillation. As mentioned, it is a much faster, safer, and far more effective procedure in our experience. We have treated nearly 1,000 patients here at St. Mark's since we got this technology just a little over a year ago. It has really changed what we do. This is the device that we use. It's called the FARAPulse pulse field ablation, or PFA, the FARAPulse PFA device. It's like a 2-in-1 catheter. It can be a basket or it can be a flower, which is actually very nice. It's like a transformer, if you've ever had your kids play with those, because it allows us to get in where we need to go, get inside the pulmonary veins, treat outside the pulmonary veins, treat the posterior wall, whatever aspect of the heart we need to treat. It's been very fantastic for us. It's a same-day procedure, in and out same day. There's no cutting, no stitches. We just put an IV in the femoral vein, which is a large vein in the groin area. We tell our patients to wait 4 or 5 days before they go back to the gym. You may have a sore throat for 2 or 3 days from the anesthesia, from the anesthesiologist and the breathing tube. You may have some groin tenderness for 2 or 3 days. Chest discomfort can happen, but most of our patients don't get it with pulse field ablation. Other common symptoms? Just being fatigued. Anesthesia can beat you up. Sometimes procedures can make you tired for a period of time, days to even a week or two, typically. It is covered by Medicare and insurance companies here in the US. And once again, this has been a game changer for us. And my prediction is it's just going to be a few more years and nobody will be doing ablations the old way anymore, at least in the US. This is how we do it. We're in the left atrium. Depending on where we are, we can stamp it with this flower. It's a very soft catheter. And we've been very impressed with the safety aspect of it. It doesn't, and also spares other tissue, vascular, smooth muscle, nerve tissue. So we can't hurt the esophagus anymore. We can't hurt lung tissue anymore. We can't hurt nerve tissue. Incredibly safe, and it can also, as I mentioned, it can be a basket or a flower. It's a very fast, safe, simple, easy procedure. And what we've seen is our risk of complications from this procedure has really plummeted with this device. There is still risk. We still have to get the catheter. We have to put a large IV in the vein. We still have to run the catheter up to the heart. So there is still risk. There's always a slight risk of a stroke. But if you're an Afib patient, you already have a risk of stroke. And so there is still risk, but it is remarkably less than what we saw before. And these are just different ways we can use the catheter to treat Afib depending on where it is. So our PFA experience, as I mentioned, I've been involved with the research years before it ever became available here in the US. We started on March 1st, 2024. So we are now coming into almost 15 months with this and 1,000 patients treated. First in the Mountain States, nearly 1,000 patients treated here at St. Mark's. We now teach physicians around the world how to do this. I know this. We have our meetings here in San Diego here in the next couple of days. I'll be teaching physicians from around the world, a large contingency of Chinese doctors. I'll be giving my lectures in Chinese, teaching them how to do this technology, how to use this for treating their patients. I personally would never go back to radio frequency or cryo again. Sherry, you're a believer too? Yeah. It's been a game changer in how patients respond. So why pulse field ablation? As I mentioned, it's faster. The catheter is in your heart less than 30 minutes. So it's only in your heart a very short period of time. It's safer, as I mentioned, easier recovery with less Afib during the recovery phase. You can't hurt the esophagus, lung, or nerve tissue. It has a much lower heart bleeding risk. I don't want to jinx myself. I've done over 800 cases. I'm knocking on wood. We have not seen any bleeding whatsoever in the heart, which has been remarkably safe. In the old way, treating over 800 patients, which I've personally treated now, I would have seen at least 1 or 2 cases of bleeding from where we treated in the heart. With this, it's been remarkably safe. So I would argue a much lower heart bleeding risk, but I put a question mark there. Lower stroke risk. Our patients are doing much better. The whole risk-benefit ratio has completely changed with this technology. Better. Currently, our redo rate, so repeat procedures, about 5%. This is dramatically lower than what we saw before with radio frequency or cryo. Now, what it used to be in the past is if their AFib came back, usually something electrically reconnected, something grew back. With pulse field ablation, the reason why it came back was disease progression, or they had developed atrial flutters. As far as areas that we treat that come back, it is very rare now. We generally do not, where we treat, it is durable. So it's disease progression or atrial flutter now, which might trigger a redo procedure, but currently only 5% of our PFA or pulse field ablation treated patients have required a redo procedure. So who's going to get a successful procedure? Younger patients do better. There's less scar tissue in their heart. Their ablation is much more likely to be successful. Men, and I know this isn't fair, men tend to get better results than women. It's because men's AFib is more likely to come from the pulmonary vein area, which is easily treated, whereas women, it's more likely to be in other places. Left atrial sizes. If your left atrium is normal size, you tend to get an excellent result. If it is severely dilated, we can still safely do the procedure, but the chances of it working long-term are lower. Paroxysmal patients do better than persistent. By paroxysmal, your AFib starts and stops on its own. These patients get excellent ablation results. Patients who are stuck out of rhythm, their results are not as high. And if you've been stuck out of rhythm continuously, 24/7, 365 for a couple of years, then the chances of a successful ablation go way down. Treating it earlier rather than later. We've published studies showing the quicker we can get it treated, the better your long-term success rate. Because the longer you're in AFib, the more degenerative effects it has on the hearts. Also, thinner patients, leaner patients, tend to get better results than people who are carrying extra weight. Also, what is new here just recently, Medicare and insurance companies in the United States have now allowed us to do ablation and a Watchman in the same procedure for those that qualify for both. So this is something that is new, and for those patients who qualify for both and who want both, this is now an option. We have to jump through a few extra hoops to get the Watchman approved, but we can now do an ablation and the Watchman during the same procedure and have it covered. About 10 more minutes. For those of you here, click on your microphone. Online people, you've got some on. We'll start here.